Hi, everybody. You are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering, and evaluating medical education programs worldwide. Today, we will be speaking with Paul Ladenson, John Eager Howard Professor of Endocrinology and Professor of Medicine, Pathology, Oncology, Radiology, and Radiological Science, as well as International Health at Johns Hopkins University School of Medicine, where he is also a University Distinguished Professor. At the end of the podcast, learners should be able to understand the relationship between hypothyroidism and cardiovascular disease, design care plans for patients with hypothyroidism and subclinical hypothyroidism, especially those with conditions impacting other organs, and identify patients who would benefit from LT4 therapy. This podcast is part of the continuing medical education program entitled Hypothyroidism 2025, Impact on Reproductive, Renal, Hepatic and Cardiovascular Health, targeting endocrinologists and other healthcare professionals involved in the diagnosis and management of thyroid disorders.
Hello, I'm Paul Ladenson, Professor of Medicine at Johns Hopkins, and it's my pleasure to present today comments regarding the cardiovascular consequences of hypothyroidism, their reversibility, potential complications of treatment, and the implications of these relationships for strategies related to the screening of patients for hypothyroidism.
What are the ways in which hypothyroidism can cause or exacerbate cardiovascular diseases?
The thyroid hormones have a number of vital regulatory effects on the cardiac electrical conducting system, both systolic and diastolic myocardiocyte performance, and on the peripheral vasculature. The thyroid hormones have regulatory impact on the sarcoplasmic reticulum calcium ATPase that's critical for diastolic relaxation. It also has important effects on both the sodium potassium ATPase and sodium calcium exchanger that affect heart rate and heart rhythm. There are effects as well on myosin ATPase and other critical genes regulating systolic performance. In terms of the peripheral vasculature, thyroid hormones result in vasodilatation and hypothyroidism, vasoconstriction, resulting in diastolic hypertension. The thyroid hormones also have critical effects on the peripheral vasculature, resulting in vasodilatation and hypothyroidism in vasoconstriction, a doubling in humans of peripheral vascular resistance with overt hypothyroidism, resulting in diastolic hypertension. There are also, along with hypertension, important effects on thyroid hormones on lipoprotein metabolism, particularly in causing elevation of LDL cholesterol, further increasing the atherogenic risk of the hypothyroid state. In addition to these effects, there are well-described impacts of thyroid hormone on the peripheral endothelium itself.
Does thyroid hormone treatment for hypothyroidism reverse these problems? And if so, how?
Fortunately, these manifold actions of thyroid hormone and the impact of the lack of thyroid hormone in hypothyroidism are almost all reversible. The sole exception is fixed atherogenic lesions that will not necessarily be resolved by the treatment of hypothyroidism. But the effects on heart rate, the bradycardia characteristic of hypothyroidism, is uniformly corrected with a return to normal sinus rhythm. The effects of thyroid hormone on myocardial performance, both systolic function and diastolic function, have been shown in many studies to be reversible. All of this by virtue of the effects of thyroid hormone, principally T3, acting within myocardiocytes and conducting system cells, T3 to activate the genes that I mentioned at the outset. With regard to diastolic function, the sarcoplasmic reticulum calcium ATPase, systolic function, the myosin ATPase isoform regulation. And an additional important effect we haven't talked about up until now is that of thyroid hormone on expression and activity of the beta adrenergic receptors, particularly the beta 2 adrenergic receptor. Thyroid hormone increases the number of that receptor species and augments its sensitivity to adrenergic stimulation. Consequently, in hypothyroidism, the lack of that normal sympathetic tone is responsible for some of the changes we've mentioned, the bradycardia, decreased myocardial contractility. Now, these effects can exacerbate heart failure in patients with a predisposition to heart failure. And in rare circumstances where hypothyroidism has been profound and prolonged, a lack of thyroid hormone in its own right can be a reversible cause of heart failure. Secondary to the decrease in left ventricular performance, there can be dilatation of the left ventricle, and in severe cases, a failure of apposition of the mitral valve leaflets, causing a reversible form of mitral regurgitation and further myocardial dysfunction. In short, all of these effects on myocardial performance, the cardiac conducting system, peripheral vasoconstriction, are changes that we can expect to get better when hypothyroidism is properly diagnosed and treated. It's only when the metabolic effects of thyroid hormone deficiency are predisposed to atherosclerosis and fixed lesions that there may be some residual cardiovascular disease even when hypothyroidism is effectively treated.
Are there any risks of thyroid hormone therapy provoking cardiovascular problems?
There certainly can be, and they are the result of the same actions, particularly on the cardiac conducting system, that we've talked about before. Tachycardia is a characteristic consequence of thyroid hormone excess. Iatrogenic thyrotoxicosis, treating patients with too much thyroid hormone, also predisposes individuals to atrial tachyarrhythmias, particularly atrial fibrillation. Even just subclinical hyperthyroidism, patients in whom the free T4 and T3 are normal, but the TSH suppressed, even in those individuals, the modest excess of thyroid hormone is associated with a 2 to 3-fold higher risk of atrial fibrillation. Also, thyroid hormone, of course, regulates the basal metabolic rate of almost all tissues in the body. And as a consequence, this is an important determinant of myocardial oxygen demands and demands on the heart for delivery of oxygenated blood to peripheral tissues. It's been well described since the early days of thyroid hormone therapy that the initiation of thyroid hormone therapy in patients with severe hypothyroidism and underlying atherosclerosis can cause myocardial ischemia. It's an important potential adverse effect, and it's led to the widely shared dictum: it's best when starting thyroid hormone therapy in a patient with known or suspected atherosclerotic coronary heart disease to start low and go slow. Meaning, in the case of levothyroxine therapy, initiating treatment with a 12.5 or a 25 microgram per day dose and increasing at 4 to 6 week intervals in modest 12.5 to 25 microgram increments.
Is prevention and treatment of cardiovascular disease a reason to screen for hypothyroidism with periodic TSH measurement?
Whether this routine screening of populations for hypothyroidism, so individuals, principally individuals with subclinical hypothyroidism, can be identified and treated, is a controversial issue. There is substantial evidence that it represents a cost-effective strategy. And the guidelines of the American Thyroid Association, based upon health economic analyses, have argued that it makes good health economic sense to measure the serum TSH in adults 35 or older every 5 years. And the benefits of that strategy are principally in the realm of cardiovascular disease and of the metabolic precursors to atherosclerosis, especially elevated LDL cholesterol concentration. In lipid clinics from around the world, patients referred for hypercholesterolemia are found 7% of the time to have underlying hypothyroidism, illustrating the potential value of taking the simple step of periodically measuring TSH in adults and then thoughtfully deciding whether the institution of levothyroxine therapy makes good cardiovascular and general health sense.
What take-home messages do we have at the end of this podcast?
The thyroid hormones have very important actions on cardiac performance, both inotropy and chronotropy, as well as diastolic functions. They also have an important action on the peripheral vasculature, and the lack of thyroid hormones consequently lead to a less powerful left ventricle, a slower heart rate, and a higher diastolic blood pressure by virtue of vasoconstriction. Fortunately, all of these effects are reversible with the identification of patients with hypothyroidism and their proper treatment with levothyroxine, all except atherosclerosis that may have occurred during a period of undiagnosed hypothyroidism. Thyroid hormone therapy in patients with atherosclerotic coronary disease or suspected of having it needs to be initiated cautiously, but acting with guidance from clinical practice guidelines, the cautious introduction of levothyroxine therapy can be safely undertaken in virtually all patients.
Thank you for listening to this Medea podcast. For more information about our continuing medical education programs, please visit our website at medeaacademy.com.